Okay, folks, please come back in.
Rochester people can't take cold in New Orleans. Hardly know one another.
Okay. Welcome back to the last three speakers this afternoon. And I did not like that you have your brownies. I don't like you have your cookies. And I was told there's also free lines cookies out there that we're going to put you to sleep again. So we will try. I'll do the same thing and walk around to keep you awake if I could. Now, the last three speakers are really great. It's an area that I'm familiar with. I'm a gastroenterologist, as you probably know. And I also knows how to cook. So we'll talk about diet. And we start this afternoon session is to be given by Dr. Danny Rains, who is a gastroenterologist, my colleague, but he's here in Osner, down here in LSU. And he will be talking about diarrhea. And so enjoy your brownie where he's talking about diarrhea. Okay? Okay. Then he will tell you whether your diarrhea is related to your disease, or it was related to your brownie, or it was related to your treatment. That is all yours.
So this afternoon I'd like to talk about chronic diarrhea, which is really an important symptom for a lot of patients. It's a major, for some patients it has a major impact on their quality of life, especially if they have severe diarrhea. And what Dr. Walchingen asked me to do is kind of describe causes of chronic diarrhea, how they're related to neuroendocrine tumors, how they're related to treatment, and how this symptom may be related to something else besides the neuroendocrine tumor or the treatment that you've had for neuroendocrine tumor. And so that discussion includes a little bit of understanding about what are the causes of chronic diarrhea classes and some specific treatments for specific conditions. So generally, I'd like to describe the basic classification of diarrhea, and this is standard for gastroenterology. We like to classify diarrhea into 4 different types. We'll review the causes of chronic diarrhea that are specific for neuroendocrine tumor patients who have been diagnosed with a neuroendocrine tumor or treated for neuroendocrine tumor, and then review specific therapies for specific diarrheal illness. So how do we define diarrhea? There's 3 definitions in the medical literature. One is diarrhea is defined as greater than 3 stools per day. The second is a real research tool that nobody ever does, which is actually measure your stool and weigh your stool, which nobody does, but in some studies they've done that in research lab. And the third is the practical definition that we actually use. So what's diarrhea to you. So if normal for you is before you were diagnosed with a neuroendocrine tumor or before you got sick, you had 1 bowel movement every other day, that's normal. And then 2 episodes of watery stool per day is diarrhea. Whereas somebody may have, at a healthy baseline, had two normal bowel movements a day, and then that's normal for them. But then when they have 4 and it's more liquidy, then that's diarrhea. So diarrhea is really defined by change in stool consistency and frequency from baseline. So before you got sick, how many times you were going a day to now is the definition of diarrhea that we use. There's also a classification of diarrhea in acute versus chronic. Acute is less than 2 weeks in duration, and it's almost always infectious, sometimes medication related. And chronic diarrhea is greater than 4 weeks. There's a lapse in there where diarrhea that lasts between 2 to 4 weeks is called acute persistent diarrhea, which is usually infectious also. Acute diarrhea is easy because it's usually infectious, and then by definition it just goes away. But chronic diarrhea is very difficult because commonly it's from multiple factors. It's hard to make it go away. It's hard to find the cause. And one of the reasons it's hard to find the cause is because there's so many causes of chronic diarrhea. And the list of causes is kind of like as long as your arm. And this is a very short list. So I listed the causes of chronic diarrhea, and this is a short list, into 4 classes of diarrhea. And that's how we like to define diarrhea, to break it down into a specific class to kind of shorten the differential diagnosis and shorten the treatment options. So there's osmotic diarrhea, which was when you ingest something like an unabsorbed sugar, like magnesium or sorbitol or something like that, and it flushes out the other end, and that's osmotic diarrhea. Secretory diarrhea is related to either a hormone-secreting tumor, which we're all familiar with, and that's one of those causes in that class. Persistent infection, and namely it's C. difficile colitis, can cause somewhat of a persistent infection. There's secretory diarrhea is related to inflammation from bile acid irritation of the colon for patients who have had resection of a short segment of their ileum, and bile spills into the colon, causing irritation. And then patients with intestinal resection, sometimes they get a secretory diarrhea. There's fatty diarrhea, which is from pancreatic excrement insufficiency, and that's from patients that have had pancreatic resection or patients on octreotide therapy where there's suppression of pancreatic juice production. Small bowel bacterial overgrowth is also a cause of fatty diarrhea, where the extra bacteria in the gut digest or break down your digestive enzymes, and so you don't absorb fat very well. And then there's inflammatory diarrhea, which is seen in patients with radiation therapy or patients with a history of inflammatory bowel disease or microscopic colitis. Commonly, we see patients, especially patients that have complex histories, have complex diarrhea. So they have diarrhea from a number of causes. So yes, your diarrhea may be related to hormone production from the neuroendocrine tumor, or yes, your diarrhea may be related to octreotide therapy, but sometimes there's another cause, or there's 2 or 3 causes of your diarrhea. So if you have diarrhea 10 times a day, and it's probably from small bowel bacterial overgrowth, or it's probably from a hormone-secreting tumor. It could also be worse because of lactose intolerance, because of a high-fat diet, because of another diagnosis such as ischemic colitis, or microscopic colitis. So complex diarrhea is common in this population where there's been a lot of treatments, there's a lot of comorbidities. So if we can get rid of or diagnose and treat one of the causes, say 1 out of 2 or 3 causes, then we can make the diarrhea better. And that's really a first step to improving this symptom. So when I evaluate patients with a complaint of chronic diarrhea, first I want to describe the symptom of diarrhea. How many times are you going per day is really what I want to know. And I'm going to use that baseline number to try to improve that symptom. So if somebody complains that they have 10 water stools per day and I have an intervention or a treatment, then I want to reassess that symptom on their return to clinic. Now it's 5 times a day because I took this medicine or made this change in my diet. And then also I want to exclude fecal incontinence as the complaint. So inability to hold onto stool is a different complaint with a totally different differential diagnosis. So that complaint as the major complaint is a different symptom and is not really included as the chronic diarrheal symptom. So we like to separate out that complaint as a different complaint. Inquire about alarm symptoms such as nocturnal diarrhea, bleeding, and weight loss, which are not symptoms of simple diarrhea. And nocturnal diarrhea is a major alarm symptom. So some patients with a history of neuroendocrine tumor that was kind of dismissed as irritable bowel syndrome may have remembered that they had diarrhea and it woke them up from sleep. And that's pathologic. That is not irritable bowel syndrome. That is not a benign symptom. So if you're sleeping and you have to wake up to go to the bathroom, that is a concerning symptom, and that is a pathologic symptom that we really pay attention to. And then also review their intake of unabsorbed sugars, milk products, and caffeine, because that could be either the cause of their diarrhea or it may be exacerbating their diarrhea. So unabsorbed sugars are like sugar-free candy, sugar substitutes. When you take in Splenda or Equal or one of these sugar substitutes, it doesn't go in your system. It just flushes out the other end and people get diarrhea. And typically we see diarrhea related to the sugar substitutes when there's an excessive intake not just kind of one Splenda a day, but people that eat a lot of sugar-free candy or have 5 cups of coffee with 2 Splendas in each or some other sugar substitute, that can really make their diarrhea worse. So pay attention to that. Also, milk product intake. Some people don't realize that as we get older, we get lactose intolerant. So we used to not be lactose intolerant, and we think that we can drink, eat ice cream and drink milk, and it's not going to give us diarrhea. But as we get older, we lose that enzyme that helps us metabolize or break down and absorb milk products. And so you get lactase deficiency as you get older. So it could be that if you stopped all your milk intake or milk product intake for a couple of weeks, you might notice that your diarrhea gets better. So that's something also that's important in the history. And then as far as medical history that's important for patients with a history of neuroendocrine tumor is history of pancreatitis or pancreatic injury. So that might be a suggestion of pancreatic extra insufficiency where you don't have enough pancreatic enzymes to digest your food and you get fatty diarrhea. Radiation therapy in some cases causes inflammation of the intestine and diarrhea related to that inflammation. And that can be seen years later. So 10 or 20 or 30 years later, patients will get symptoms of chronic diarrhea from radiation therapy they've had many years ago. Intestinal surgery, which a lot of patients with neuroendocrine tumors have had, this commonly results in malabsorption, commonly related to small bowel bacterial overgrowth, where there's segments of the small bowel that have pockets that accumulate extra bacteria. They break down your digestive proteins so you can't digest your food, and you get mostly fatty diarrhea. Also, in patients that have had resection of their ileocecal bowel, there's reflux of bacteria from the colon into the small bowel now, and that's associated with increased risk of small bowel bacterial overgrowth, which results in maldigestion and diarrhea. Family history is also important just because patients that have a family history of inflammatory bowel disease or celiac disease may have this as an additional diagnosis and additional cause of diarrhea in their case. So the basic evaluation is stool studies, which I would like to use to classify patients into the one of 4 classes of diarrhea. I would like to say it's nice and easy that we can do osmolarity and fat analysis and white blood cell analysis to classify patients' diarrhea, but it's usually not that straightforward. Commonly, patients have complex diarrhea, and it's also oftentimes it's difficult to get an accurate stool analysis. Patients don't want to submit the sample, the lab doesn't want to collect the sample, the lab doesn't want to run the sample, and it gets lost a lot because nobody wants to deal with the stool sample. Or they'll say it's not liquidy enough, or it's not enough of a sample, or it's too much, or whatever, or it's been sitting too long. So it's difficult to get an accurate stool analysis. And also, again, commonly it's difficult for us, or it's not unusual that we can't clearly classify somebody into one of the 4 groups by their stool studies. But some patients can, and it's a basic test. It doesn't have any risk with it, so we like to do that as an initial test. A fat analysis is generally a Sudan fat stain. It's just a fat stain to look for quantitative globules of fat in the stool. There shouldn't really be any fat in your stool. You should kind of absorb it all. And there's really a 1+, 2+, 3+ result from that test. Don't let anybody talk you into doing a 72-hour fecal fat. And that's the textbook way of measuring fat in the stool. They put you on a certain diet with a certain amount of fat per day. Then you collect your stool for 3 days, and then you turn it in this little container, and they're supposed to analyze it and see how much fat's in it. And that's really the way that's been proven in the past and validated in the past to analyze the fat malabsorption. But it's not a very good test. It's very difficult to do. Nobody wants to do it. And it's not really that much better than a Sudan fat stain. So to do that test, they also have to analyze the stool in a certain time period because the bacteria digest the fat and everything. So if somebody says, well, I read the textbook that I'm supposed to order a 72-hour fecal fat, say, no, can't we just do a Sudan fat stain instead because it's really almost as good. And that's what I'd recommend. And then endoscopy. We use endoscopy with mucosal biopsy to look for inflammation. I look for celiac sprue. I look for inflammatory bowel disease as another cause of complex diarrhea or a concomitant illness. And then also I look for microscopic colitis, kind of microscopic irritation of the colon, which we'll also talk about. And then specific testing depends on the particular etiology. So if you're looking for a specific illness, I'll do a specific test for that illness or condition. Evaluation and management of chronic diarrhea is different than a lot of other medical testing. In that, when we have patients with this symptom, sometimes we'll just give them the medicine for what we think they have, and if their diarrhea goes away, then that's the diagnosis, which is kind of counterintuitive. You'd like to say, well, I have this condition, I want to do this blood test or test to show that I have this condition, and then I want to take the medicine for it. But proving different causes of chronic diarrhea is oftentimes difficult and not very straightforward. So a lot of the treatments for chronic diarrhea, for different causes of chronic diarrhea, are very benign. They don't have any side effects, or they're a change in diet, or say, for example, you would not have any milk products or taking any milk products for 2 weeks. Something like that is very benign. So a lot of times there's this therapeutic trial of, I don't want you to have any milk product for 2 weeks and see if your diarrhea goes away. And I'm making a guess as the cause of diarrhea, but there's no risk with that, so patients say sure. And if their diarrhea goes away, then they have lactose intolerance. And so there's a lot of that in this evaluation algorithm, and I'll talk about some of those specific interventions that we can try. So this is a subject, those next few slides, that you all know very well. Yes, diarrhea in this population is commonly related to neuroendocrine tumor, either hormone production or treatment of the neuroendocrine tumor. Diarrhea is the second most common cause of manifestation of carcinoid tumors following flushing, and occurs in 70% of cases. And this is a secretory diarrhea. And so when patients have secretory diarrhea, their diarrhea persists even when fasting. So even when you're not eating, you have diarrhea. And that's a common symptom also with nocturnal diarrhea. So secretory diarrhea, people wake up from sleep with diarrhea. They haven't eaten for 8 hours, but they still have diarrhea. So this hormone-related diarrhea is a secretory diarrhea that we see with neuroendocrine tumors. And again, this diarrheal symptoms is not improved with fasting, and this is in sharp contrast to malabsorptive diarrhea, where patients that have had pancreatic insufficiency, either from octreotide therapy or surgery, or if they've had intestinal surgery and they have small bowel bacterial overgrowth interfering with their digestion, they get malabsorptive diarrhea, or an osmotic or fatty diarrhea. And that's a diarrhea that gets worse when they eat, and if they don't eat for a day or two, then their diarrhea goes away. So if your diarrhea persists when you're fasting, say you didn't eat anything all day, or for a day and a half because you were getting prepped for a procedure or whatever, then if your diarrhea doesn't go away, then it may be hormone related. It's a secretory diarrhea. Whereas diarrhea that resolves with fasting is malabsorptive diarrhea. And so we can use that different symptom, that change, that differentiation in symptoms to classify people's diarrhea, to kind of narrow down this long list of causes of diarrhea. So besides hormone-secreting tumors that result in secretory diarrhea, there's 2 other forms of diarrhea related to neuroendocrine tumors directly, and that's patients with gastrinomas produce so much gastric acid that they break down their digestive proteins that they use for normal digestion, and they get malabsorptive diarrhea, namely fatty diarrhea, rather than a secretory diarrhea. And then patients with stomatostatinomas that behave similar to patients on suppressive octreotide therapy, where this excessive somatostatin results in suppression of digestive enzyme secretion, and then they also get malabsorptive diarrhea, predominantly fatty diarrhea. Now, medication-induced diarrhea, octreotide therapy is a common culprit that we think about. And yes, that's a common cause of chronic diarrhea, but we'll focus on this cause and other causes. Somatostatin analogs inhibit secretion of pancreatic juice, gastric acid, and gallbladder motility, and this results in impaired breakdown of and absorption of food, primarily fats. And this is treated with pancreatic enzyme supplementation, may help control your diarrhea, and it's usually with a lipase supplementation of 30,000 units per meal. And that's an important number where that's been fairly well validated also. Pancreatic enzyme supplements come in a lot of different forms. Commonly it's multiple pills, and somebody's asking you to take like 4 pills with every meal, and it seems like a lot. And that's the number I want you to remember, is you should be taking about 30,000 units of lipase per meal. And that's the best marker of how much pancreatic enzyme you should take. If you really do have fat malabsorption from pancreatic enzyme insufficiency, either from pancreatic surgery, pancreatitis, or octreotide therapy, then it really should get better with pancreatic enzyme supplementation. And if it doesn't get better at all, then I'd be kind of skeptical whether that's really the cause of your diarrhea. Other medications that can induce diarrhea are commonly proton pump inhibitors. Some patients just get chronic diarrhea, and that's just in the general population. Maybe a few % of patients that are on PPI therapy get chronic diarrhea from that drug, and when they remove it, it goes away immediately. Supplements, namely with magnesium-containing antacids or a phosphate-containing supplement can cause diarrhea. Other medicines that aren't common in patients with neuroendocrine tumors but may be in your medication list include colchicine, theophylline, misoprostol. There are a number of antineoplastic agents that have been used for management of neuroendocrine tumors that cause severe diarrhea. And in these therapies, commonly the doctor can tell you and will tell you that I'm going to give you this chemotherapeutic agent, it's going to give you diarrhea. And then when I take you off, it'll go away in about 2 weeks. So there shouldn't be a lot of confusion as far as the cause of diarrhea with one of these agents, because whoever's going to give you one of these drugs is going to predict that you're probably going to get diarrhea and tell you that in advance, and then tell you when it's going to go away. And it shouldn't be this kind of question as far as, I don't know why you're having diarrhea. Let me look at your medication list. That's not usually how it goes. It's that I'm giving you this drug, I know it's going to give you diarrhea. So that's not commonly what we include. Even though these drugs can cause chronic diarrhea, it's not commonly included in my list of strange causes of diarrhea or unknown causes. So a few of these causes, we're going to go through some specific etiologies that are specific to neuroendocrine tumor patients. Some patients, as I reviewed before, have small bowel bacterial overgrowth, which is excess bacterial breakdown the normal digestive enzymes required for normal digestion, and they get fatty diarrhea. Also, patients with intestinal surgery, besides having pockets of fluid or accumulation of fluid in their small bowel from previous surgery or anastomosis, they have impaired motility related to nerve injury, and that's the cause of diarrhea that we see in some patients with previous intestinal resection, especially with people with intestinal resection and resection of the ileocecal bowel. And how we diagnose this is debatable. So the way that you're supposed to diagnose it is to do either a jejunal aspirate with quantitative culture, or they have breath test analysis following a specific carbohydrate ingested meal. And both of these tests are kind of difficult to do. When you do a jejunal aspirate, you have to put fluid in the small bowel and then suck it out. And how much fluid you put, it should be standardized, but it's not really. And how they culture it can vary between labs. So it's difficult to kind of prove that, yes, there's too many bacteria in a jejunal aspirate. The same thing is true for a hydrogen breath test. There's a lot of different ways to do the breath test. What carbohydrate they give you makes a big difference in the result. How much carbohydrate they give you makes a big difference. How they capture the breath test makes a big difference. How many times they capture it makes a big difference. So there's not a lot of standardization between labs. So some labs that do hydrogen breath testing find that every patient they test has small bowel bacterial overgrowth. And some labs find that nobody has small bowel bacterial overgrowth. And that's because it's not a very standardized test. I think that we can still make some advances in how we standardize hydrogen breath testing to diagnose small bowel bacterial overgrowth. I got a better way of diagnosing small bowel bacterial overgrowth, which is just to give you an antibiotic and see if your diarrhea goes away. And that's what we use. And that's because the medicine that I would use has no side effects, and commonly we use rifaximin, which is an expensive drug, but it's not absorbed in the systemic circulation, and it kind of kills all the bacteria in the gut. And if you take that drug for, say, 10 days or 2 weeks, and your diarrhea goes away, then yeah, you have small bowel bacterial overgrowth as the cause of your symptom. Now, that might not always be really easy to treat, but at least we're starting with a known diagnosis. I know why you have diarrhea now, because I gave you a therapeutic trial with this antibiotic and your diarrhea went away. So that's the common way we diagnose small bowel bacterial overgrowth in many centers, even though it's more scientific to do a jejunal aspirate or hydrogen breath test. Or if you bought the really expensive hydrogen breath test equipment, then you want to use your hydrogen breath test machine. And then in addition to antibiotic therapy, we treat patients with small bowel bacterial overgrowth with a low carbohydrate diet, so they don't have as much kind of discomfort from gas production from breakdown of carbohydrates by the extra bacteria in the gut. And then avoid narcotics and anticholinergic, which kind of slow down gut motility and promote bacterial proliferation from lack of motility. Short bowel syndrome is a disease where we resect large amounts of the small bowel, and this results in malabsorption of nutrients and osmotic diarrhea, or malabsorptive diarrhea. And that's typically, it's defined as less than if you have less than 200 centimeters of small bowel left. It kind of depends on which part of the small bowel they removed. The ileum, Resection of the jejunum is generally better tolerated than resection of the ileum. The small bowel tends to adapt, so that if you resect a piece of small bowel, the rest of the small bowel tends to adapt to kind of adopt the functions of the small piece of bowel that was removed. But it takes time, and in these cases, it'd be preferred to resect again a piece of jejunum rather than ileum, if possible. Or it's hard for us to select what's going to be done, but that's better tolerated. And again, it's also better tolerated if the ileocecal valve is preserved, and that prevents fluid from kind of rushing into the colon, and also prevents bacteria from refluxing into the small bowel, resulting in small bowel bacterial overgrowth. The treatment of small bowel short bowel syndrome is frequent small meals, avoiding high carbohydrate eating, because excess in carbohydrates in the gut sequester fluid into the gut lumen and exacerbate diarrhea, and they're also broken down by the extra bacteria or any extra bacteria in the gut. Supplement vitamins and minerals as needed, and Leanne will probably talk a little bit about that. And then we treat these patients with antidiarrheal agents, and then you can expect slow improvement. Commonly it takes a year or two for the gut to adapt enough for the diarrhea to improve, but it does improve commonly over time. We're going to talk about bile acid and bile deficiency diarrhea, which are two different causes of diarrhea, chronic diarrhea, in patients with ileal resection. Patients with ill disease or previous resection, a short segment that's resected, especially at the end of the ileum, bile acids spill over the colon and irritate the colon, causing kind of a secretory diarrhea. And how we diagnose this is to give a trial of a bile acid binder to see if your diarrhea goes away. And namely, that's cholestyramine. And so we use that to confirm a diagnosis as well as manage symptoms. Now, some therapeutic trials I can kind of, not guarantee, but I can predict with a fairly high likelihood that lack of improvement with therapeutic trial is significant. And that's not quite the same with bile acid diarrhea. If I give you cholestyramine and your diarrhea doesn't get better, I can't promise you don't have bile acid diarrhea, like I can with small bowel bacterial overgrowth and zyphoric rifaximin, or with pancreatic X-ray insufficiency and pancreatic acid supplementation. So bile acid diarrhea, again, the treatment with cholestyramine commonly is effective, but it's not as dramatic as some of the other conditions. So this is a condition that we still have some way to go as far as managing this cause of diarrhea, because the therapy is not highly effective in all patients. Then there's bile acid deficiency diarrhea. So if you have more than 100 centimeters of ileum resection, then you spill off so much bile acid that you don't reabsorb any of it, and you run out of bile acids, and then you get fat malabsorption because you don't have any bile acids to mix with food. And the treatment of that is a low-fat diet generally. And we generally supplement fat as medium-chain triglyceride fat or MCT oil, because if you don't have any fat in your food, you still need some fat intake, and that medium-chain triglycerides are absorbed without the use of bile acids, and so that's a supplement that we use. And to diagnose this cause of diarrhea, you'd be kind of on a no-fat or ultra-low-fat diet. There's one more condition that I'd like to discuss that has very little or nothing to do with neuroendocrine tumors, and that's microscopic colitis. And the reason I mention it is because it's such a common cause of chronic diarrhea in patients older than age 50. And we think of this condition as inflammation of the colon from something we don't know. It could be a bacteria, it could be maybe a mild autoimmune disease, it could be a food allergy, it could be a drug allergy from maybe NSAIDs, I'm not sure. But what we do know is when we find patients with this mild inflammation or microscopic inflammation of the colon, if we treat them for this condition, a lot of them get better. Now, I'm not sure really what I treated, because when I think about treating people with steroids or a medicine called budesonide for this condition, then it's kind of like I kind of compared with treatment of a rash. So if you have a rash, an itchy rash on your skin, and you're not sure what it's from, but you put steroid cream on it, it goes away. Then it went away, but you weren't really sure what was the cause. And that's the same with microscopic colitis. And that's what I think about is irritation of the colon, and we give a steroid cream that kind of coats the colon and makes the irritation go away. And I'm not really sure exactly what was going on, but their diarrhea went away. So I think that's okay in my mind as far as the result, but it's not really clear why people get microscopic colitis, and we're not sure if it's again, a food allergy or a drug allergy, or what's the cause. But we do know that these patients get better, so I think testing for microscopic colitis really by biopsy of the right colon for inflammation and treatment with therapeutic trial is reasonable to see if this is the cause of your diarrhea and if we can make it go away. And then lastly is idiopathic secretory diarrhea, which is I did 1 million tests on you and I don't know why you have diarrhea. And it's a secretory diarrhea. So when it wakes you up from sleep, it doesn't withdraw with fasting, and it's a diagnosis of exclusion. So once I've kind of tested and treated for every other cause of diarrhea there is, and you have a secretory diarrhea that doesn't improve with fasting, and it's not related to the neuroendocrine tumor, then we just diagnose people with this condition, which means I don't know why you have secretory diarrhea. And we kind of cover up their diarrhea with symptomatic therapy with antidiarrheals. Some people end up on this slide, which is I don't know why you have diarrhea. I've done 1 million tests on you, and we've looked for different causes, and I've given you a low-fat diet, a lactose-free diet, and Xifaxan, and a bile acid binder, and pancreatic enzymes, and I still don't know why you have diarrhea, but it's still there. And in these patients, it's not unreasonable or unusual to treat these patients just symptomatically. And if I can make their diarrhea go away with an antidiarrheal, then that is kind of a partial success. If I can give somebody a tablet of Imodium every day and their diarrhea went away, I never really figured out what was the cause of their diarrhea, but it doesn't bother them anymore. So that is not ideal, but it's better than patients with chronic diarrhea that I can't improve. Most patients, if we treat them with enough antidiarrheal therapy, we can make their diarrhea better, and commonly a lot better. And sometimes we have to use several agents, including Imodium, paregoric, which is an old therapy, and tincaropium, which is similar to paregoric. And with a combination of these therapies, we can improve patient symptom of diarrhea, and a lot of times make it much more tolerable than it is now.